welcome to tonight's webinar. We thank you for joining us. Today, we have a special guest, Dr. Richard Schwartz. We don't get into clinical very much in the ideas, but Rick has shown some tremendous cases on the list that I'm a member of. And frankly, Rick has taught me some things that I didn't know about endo. And I figure he can, maybe I'm slow, and maybe you all know what Rick is going to show, but I doubt it. Rick is very innovative. He's been able to create some great paradigms, and has been able to save an awful lot of teeth that at one time we might have extracted in favor of dental implants. So for that reason, I thought all of us would benefit to see what endo can do for our patients. And so Rick, thanks for being with us on the IDS webinar.
Thanks, Lee. So to a group like this, obviously there's not a lot of things I can teach you. I hope what I'll do is provide you with some ideas, some things that you haven't thought about in the past. I'm going to go through a series of cases and just show you how I treated them, and with the hope that you'll be able to incorporate some of this into your practice and work with your endodontist. Kind of the underlying theme here is what endo can bring to the table in a perio practice. So let's see, let me flip up my slides and we'll get started. All right, so just in the spirit of full disclosure, I want to tell you that I have no financial relationships with any companies. I don't lecture for any of the companies, and I'm not here to sell you anything. Just a little bit of background. I've been an endodontist about 20 years. I was a general dentist for about 20 years before that. I practice in a multi-specialty practice in San Antonio. This is the building that we all built together. And I've been with some of the guys for the whole time I've been in practice, 20-some years. It allows us to do some kind of interesting, complex, kind of innovative treatments. And I'll show you some examples of that. This is a picture from a couple of years ago, actually, but this is part of the crew. We have endodontists, periodontists, orthodontists, and we had a prosthodontist, actually. She left not too long ago, but some of you may know Brian Schroeder. He's a general dentist, but he has a prosthodontic type practice. Whenever you're an endodontist, you have to show a picture of yourself working under the microscope. So here's mine. A couple things you might notice about how we do things. Both my assistants and I have armrests for stability. We photograph a lot of the work that we do and use it in lectures, use it in patient education. I have my oculars that I work for. My assistant has her oculars, so she can see exactly what I'm seeing. It's particularly helpful. We do a lot of restorative, a lot of the initial restorative in our practice. We do a little bit of surgery, and mostly just conventional root canal treatment. It's very helpful having your assistant being able to see what you see. So this is a quote from an article I wrote for the endodontists a number of years ago. It says, in dentistry, everything we do is temporary except extractions. And the way we're trained as dentists, we kind of think that everything is permanent, but in reality, everything is temporary. And the point is that we need to be planning for the future, planning for future failure, just like sophisticated restorative dentists do. So this is the first case I'm going to show you. This patient was referred to me by periodontist. Some of you may know him, Ken Kruger, really outstanding periodontist who practices actually on the other side of San Antonio. We work together quite a bit. He referred this patient to me. The history is about 2 years earlier, the patient had, quote, a cyst removed and had the area grafted. As you might suspect, this was done by an oral maxillofacial surgeon. Periodontists don't usually put screws and meshes and things in there. When I show this case, I lecture a lot to study clubs and small groups. And when I show this case, in a lot of the cases, I ask questions. And so one of the questions I ask them is, how's the graft doing? And usually somebody pipes up and says, well, it's not doing very well. It's got radiolucency around it. So then I ask them, so why did a periodontist refer this patient to an endodontist? Obviously, they're going to regraft this. What was the point of sending it to me? And usually the audience is stumped. And the answer is, the periodontist wanted me to evaluate the teeth on either side of the space. for endodontic issues. So this tooth was tender and hyperresponsive to cold, what we would call irreversible pulpitis. This tooth had a necrotic pulp. So then I'll ask them, so again, why did they bother sending this to an endodontist? Why not just extract these two teeth? I mean, this one's a loser for sure, the molar, and the premolar's got poor crown to root ratio. Why bother with all of this? And the answer is that, again, this usually stumps people in the audience, but the answer is that he wants to keep these teeth around for a while he goes through the process of regrafting his site, because he wants to get as much vertical height of graft as possible. What I would say, very smart treatment planning. This guy is really an outstanding periodontist. I give him a lot of credit. So that's what we did. In case you're wondering what this picture is, this is the graft material, and a little bit of the one of the screws is eroded through the soft tissue. So then we scan this patient, as we do with most of our patients. And again, I'll ask the audience, so what sort of information are we trying to gain from this scan? Well, we're interested in what kind of graft site this is, how much vertical and horizontal bone there is. From my standpoint as an endodontist, I'm interested in this screw. Is it sticking into this root? Because if it is, then for sure this tooth is a loser. I'm also interested in knowing if the tip of this root is actually in the radiolucent area here, the area with bone loss. Because we've seen on a number of occasions where grafts or implants have devitalized a tooth, and then it's like the tooth got back at them by causing the graft or the implant to fail. That may be what happened here, because this was actually sticking into the area where of bone loss. I also mentioned the periodontist is interested in the relationship here to the inferior alveolar. So the scan showed us that, in fact, the screw is not sticking into the mesial root, just superimposed on the other, on the PAs. And it answered the other questions that I mentioned. So I started root canal treatment on both of these teeth on either side of the space, put calcium hydroxide in there. The idea was we were just going to leave them this way, allow the patient to become asymptomatic, clear up the infection associated with this tooth, and just leave it this way for a few months while he regrafted it. So knucklehead that I am, I broke off a file in the mesial root in the process of doing the pulpectomy on this molar. And so I thought, well, that's for sure, that's the end of this tooth if there was any question before. But ultimately, he regrafted this area and got a pretty nice result around the mesial root. Patient was asymptomatic. He said, you know what, the patient's not ready for the implant anyway. Go ahead and complete the root canal treatment on those teeth. And so that's what I did. And I followed this patient over the years. She had a number of implants put in other areas, and she was just tired of it. She wanted a break from it. So when I saw her at 2 years, she still hadn't had the implant placed. And here we are at 5 years, and then I just saw her recently, 6-year recall. So I really give this periodontist a lot of credit. This is very smart treatment planning. She's so much better off than if he would have just extracted these two teeth. In fact, it's hard to see how this could have turned out better. At some point, presumably, she'll get a bridge or an implant put in here, and we'll have a very nice result. So I put this case in as an example of kind of the principle that I've talked about to my periodontists over the years, the ones I work with. And that is, when you have these perio-endo lesions, don't be in a rush to go ahead and do the perio. This patient was referred to me by a periodontist. Deep probings, bleeding, pus through and through. Really a hopeless looking situation. This was, I think, in 1999, actually. And it was before implants really had become a mainstream treatment, at least in our area. And so the periodontist's idea was that she wanted me to do the endo, and then she was going to do a distal buccal root out. So I did the root canal procedure, and I told the periodontist and the patient, let's not do anything for about 6 months or so. Let's see how much bone fill we get just as a result of the endo. And I saw the patient at 6 months, and by golly, the furcation was totally filled in with bone. And again, I've followed this lady for a while, and these are both 15-year recalls. So more than likely, if she'd had the root amp done, probably this tooth would be gone now.
Rick, if you're looking at this from a diagnostic standpoint, so the periodontist sees the patient first.
Right.
What if we did conventional pulp tests? What would we have found at that particular point?
It was a necrotic pulp, and that's a great question. Yeah, if it had been a vital pulp, then we wouldn't have gotten a result like this. So this is we call them perio-endo lesions, but really this was an endo-perio. It was pretty much all endo, even though it looks like, cratering bone loss, periodontal bone loss.
And do you remember, were you able to probe into the furcation at that particular point?
You could. I mean, you could probe in all three directions. Yeah. It was, this was a kind of a miracle result. I mean, one of the things I look at when I'm thinking about bone loss and healing from endo is the level of the bone on either side of, if the level of the bone is up high here, the chances of getting furcation, bone fill and furcation are very low. But if the bone levels are, above or coronal to the furcation, you have a chance at least of getting bone fill in there.
Same principle with bone grafting. So yeah, that's outstanding.
Yeah. So it isn't always going to turn out this way, obviously, but what I tell people is do the endo, see what sort of resolution you get, and then depending on that, then, in 6 months or so, go ahead and do the perio treatment if necessary. And I have a lot of cases like this. I just, and obviously they don't all turn out this way, but I just put this one in to show you because this is a pretty dramatic one. All right, on to the next. This is a patient that was referred to me by oral maxillofacial surgeon, a little 13-year-old girl. Her face was all swollen. Again, when I show this to study clubs and things, I ask them, what do you see on the radiograph? And they say, well, the lateral incisor looks funny. There's big radiolucency here. So this is dens and dentae. If you look closely, you can see the enamel lining where the enamel is invaginated into the tooth. Sometimes it goes into the pulp and sometimes it stays separate like this. So sometimes even with the big radiolucency, the pulp will be vital. If they're completely separate, that wasn't the case here. We did a scan, and again, you can see the enamel line track here. As you go down towards the apex, you see it opens up into kind of a pouch, I would describe it. Very hard to get that clean non-surgically, with traditional endo. Also, when you go through an enamel line track, our instruments are made to work with dentin, and they don't work very well against enamel. You have to be really careful. It's easy to break an instrument. So I was anticipating we were going to have to do surgery here in addition to non-surgical treatment. But there's kind of a dilemma here. Again, when I show this to groups, I say, when you look at the sagittal and the frontal view of the scan, does anything catch your eye? And the things that catch my eye is there's hardly any bone on the buccal or the lingual here. Also, it looks like the bone loss is eroded into the floor of the nose. So I'm comfortable doing most surgeries, but I'm not that comfortable in this situation. However, if surgery is necessary, I'm the one that's best equipped to deal with the root end issues here. The oral surgeon is better equipped to handle the rest of it and potential grafting and so forth. So I asked the audience, are there any other options beside, or how would you deal with this? First thing we're going to do is treat it as best we can non-surgically, but if it needs surgery, how are you going to deal with it? We're going to do 2 surgeries. Is he going to come to my office? Am I going to go to his office? How are we going to do this? And again, usually the audience is kind of stumped. And so I told them, well, this was our plan. First of all, I made access and dual access in here and prepared the canals as best I could. Put calcium hydroxide in, and as you can see, I got a little carried away with the calcium hydroxide, kind of went everywhere. But my idea was that I was going to try to at least get this thing to shrink down to the point where I could just do it all, where I could do the non-surgical and the surgical and be comfortable. I was also concerned about possibly devitalizing these adjacent teeth if we had to do surgery with this being so large. So that's what we did. I changed the calcium hydroxide at a month, and at 3 months, look at all the healing we've got. Just amazing. Kids are amazing healers. And so Let's see. Here she was at 6 months. We completed the endo, almost completely healed. And I followed her now. This is an 18-month recall. You can see we did a scan and pretty much complete healing. We never had to do any surgery, in other words. And I saw her recently. This is a 6-year recall. She's in college now. So again, it's hard to imagine how this could have turned out any better. You know, in a 13-year-old, certainly you wouldn't want to extract this tooth if you didn't have to. She'd have to probably wear something removable for a long time before you could place an implant in here. Can't really do a fixed bridge on somebody that age. So this was, again, kind of an ideal outcome.
Are a lot of foresight on the part of the oral and maxillofacial surgeon as well. I'm not sure that every oral and maxillofacial surgeon would have made that referral to you.
That's absolutely true. The thing is, we work a lot with periodontists and surgeons. We've developed these relationships, and when I lecture to endodontists and residents and stuff, I say don't write off the implant surgeons. A lot of them, especially the older ones, they really would prefer to hang on to the teeth if it makes sense, if it's possible. And actually, last year, is it last year? Yeah, last year or the year before, I forget. My number 6 referral was an oral maxillofacial surgeon, actually. He wasn't the one that referred this patient, but he sees a lot of cancer patients and refers them over. So,
Okay, so I'm a member of I run a business organization, so let's talk about the business aspect for a second. So is this due to lectures? Is this due to personal relationships? Are you sending out examples of your cases on a regular basis to everybody in the community? Combination of the above. What are the keys here from that standpoint?
So in my situation, I'd say it's the first 2 things you mentioned. I lecture in the community quite a bit and show this kind of stuff. In fact, I'll lecture to any group, anytime, within about 3 hours of where I practice. And it's paid off big time over the years. I have a lot of patients that come from 3 hours away from Laredo. I've established relationships with these people, and you know, patients that travel 3 hours, they're very committed patients, and they're expecting to pay big city prices, and they're just great patients. There's some downsides, obviously, to having patients that far away if they have problems, but it's been a big boon to our practice. And then secondly, I mean, it's a relationship business that we're in. What I found is that the only really loyal referring doctors you have are the ones that you have a personal relationship with, you know, because there's always going to be issues that are going to come up and bumps in the road. And if you don't have a personal relationship outside of business, some of them just something goes wrong, patient's unhappy, they'll dump you and go to somebody else. There's plenty of others that they can refer to. There's plenty of other competent endodontists in San Antonio. So I've really worked over the years to establish personal relationships with as many of these people as I can. And consequently, our practice, we pretty much work with the best restorative dentists in town. There's a couple that have gotten away from us, but for the most part, most of them refer to us, even though there's other very capable endodontists that are closer to them. I don't know if that answers your question.
No, that answers the question very well. Thanks, Rick.
Yeah. Okay, so let me move on. So what if the long-term calcium hydroxide hadn't worked? Then our next plan was to do decompression. We don't do this very often, but I just put in an example in another patient. Large radiolucency, it's not healing. The purpose of decompression is to at least shrink it down to the size where we're not going to devitalize other teeth if we have to do surgery. So you make an incision in the soft tissue and then put some sort of tube in there. Like you see here, this is just a composite tip with the end cut off here, and put a couple holes in there so it could suture it in place. And then the patient flushes this out a few times a day with chlorhexidine every day. Usually about 4 to 6 weeks is enough to get the bone loss to start healing, and then you can take this out. And in some cases that won't heal just by conventional root canal treatment, this will get the process started. And sometimes they'll heal completely. Sometimes they'll just shrink down to a certain size, but then you can safely do apical surgery if you need to. This is a statement that we see sometimes made by somebody who's trying to irritate the endodontist. Endodontically treated teeth are space maintainers for implants. I'm going to kind of turn this around and show you some examples where that was the plan, this idea of planning ahead for the future. We see a lot of kids in particular that have problems with their teeth that are 14, 15, 16. They've had trauma. They've had severe resorption after orthodontics. And so in those cases, many cases, we're just trying to keep the teeth around until they're in their 20s or so, and they can, the other restorative options open up, including implants. So this is a kid that came in, 15-year-old kid that had this syndrome with a long name. I don't recall because it's been a few years ago. Never heard of it before or since. But one of the aspects of the syndrome was severe root resorption. Okay, and you can see it here. So this kid has got an infection here. 2 teeth are involved. There's a sinus tract. Our goal with him was just to keep these teeth around until he got into his 20s, to clear up the infection, regrow the bone, and then when he got into his 20s, if he makes it, have an implant or 2 placed here. So when we did the scan, one of the things we saw was that there were several fracture lines and little pieces of tooth in there. Sometimes you can just go in and do the endo and you don't have to do anything else. But when you see these fracture lines in multiple pieces, usually then you have to go in and do surgery also. And that was the case here. So completed the endodontic treatment, didn't worry too much about pushing stuff out the end, and then flapped it and cleaned things up. And here at 6 months, you can see the teeth are tightening up. You can see the bone is healing. Here's the kid at 18 months. Now these have terrible crown to root ratios, and these teeth have some mobility. But as long as he doesn't get whacked in the mouth or something, there's a very good chance that these will last. So here he is at 3 years, and here he is at 5 years. So he's 20 years old now. Potentially he's, old enough to safely place implants. But these teeth are doing fine, and we're just going to leave them there as long as there's not an issue. So these may last actually for many more years. And you see how little bone there is that's holding this in, and yet the teeth are doing, as well as can be expected. So here's an even more dramatic case. 12-year-old little boy got whacked in the mouth with a baseball, broke both of these. I didn't see him until 2 days later when he couldn't close his teeth together because these were in the way. So we numbed him up and repositioned him as best we could and stabilized him. And then his lip was all swollen and bloody and stuff. We didn't do anything that day. We had him back, other than stabilize him, but we had him back about a week later, then started root canal treatment. Same thing, this tooth, you can kind of see here, had multiple fracture lines, and the sinus tract didn't heal after a month of calcium hydroxide. So we obturated these and then flapped them. And I wouldn't have probably needed to take out this apical segment of this one. This was the one with the problem. But, this was a kid, we had to sedate him to do the surgery, and I just didn't want to take a chance. And so I took out both of these. And then here he is at 6 months. This is immediately post-op at 6 months. You can see how much healing has taken place. And there's a little bit more root and bone in these teeth, but still not, especially this one, not very favorable. But he's healing and the teeth are tightening up. And we had one of the orthodontists then put a little ortho wire on there to provide some support to these teeth. And he's still very active in sports, so there's still a chance of further trauma here. But if he doesn't have trauma, probably there's a good chance. Again, he's 17 now, last time I saw him, and everything's doing well. And if and when one of these teeth fails, it looks like maybe there's something going on here now. At least if it happens before he's 20 or so, most of the surgeons around here don't like to place implants in kids younger than 20, 21, something like that. And so at least even if this does fail and he has to have one or both of these removed, at least he won't have had to wear a removable appliance for so many years. And hopefully these will make it a few more years.
So again, this went from oral surgeon to endodontist, correct?
Right, exactly. Yep. So I have some patients I've been following for a number of years that have severe ortho resorption. This is one of them. I didn't actually do the original root canal procedure here. Somebody else did. But I've followed this little girl now for 13 years, and you can see these teeth are doing just fine, even though they have terrible crown to root ratios. And a few years ago, Vince Kokich published a couple of articles talking about this. How do patients with severe orthoresorption do? This is from one of his articles. You can see like this tooth or this tooth, there's hardly any root and bone, and yet this is a 13-year recall. And unless the patients are unlucky, they can do very well even with very short roots. So that's one of the things that kind of inspired me when this article came out about 10 years ago. Sometimes in planning ahead, so we'll do procedures in anticipation of loss of the teeth in adults also. This patient had very extensive, kind of poorly done crown and bridge, and we're anticipating that these maybe didn't have that many more years to go. The endo was failing here. There was a fairly large radiolucency. And so our plan here was, I didn't want to retreat. Normally I retreat in a situation like this, but I was afraid by the time I took the post off, need new crowns, and there'd just be nothing left of the teeth. And so I went ahead and just treated them surgically. And the plan was, if these teeth could hang together about 18 months or so, that we'd get the bone to heal, and that this would be a better implant site than just extracting and grafting. I've asked a lot of implant surgeons over the years, you know, if they have a preference of grafting a native bone or a grafted bone. I think without exception, they've said they prefer to graft in native bone. So we have a number of situations where we try to regrow the bone as a process of, you know, in anticipation of implants. That was the case here. Actually, this is at 5 years. You can see complete healing. We did a scan. Now, one downside here, there's a little bit of cupping. It's still a pretty good implant site here, but this patient maybe would have benefited from some grafting. And a similar case given to me by a friend of mine, you can see where they did grafting. And this is probably a little bit better implant site. And that previous case maybe would have benefited from some grafting. We see screw ups in kids sometimes. This is a 12-year-old that somebody did a root canal procedure and the patient was having problems, and then somebody else decided to retreat it and perforate it. So the patient was referred to us, and our goal here again is just to get this patient into her 20s or so. So I retreated the apical part. And when they perforate an anterior teeth, it's always to the facial like this. And so we retreated. This is the perforation repair that got a purchase way back here. So they're totally in the wrong place. And this is immediately post-op, gutta percha apically, composite in the fiber post and the composite on the outside. And here we repaired it internally with biodentin, which is a product we like and use quite a bit for this sort of thing. And then flapped it, placed a little flowable composite. And then here we are immediately post-op. You can see the repair. And then the last time I saw her was at 36 months, so everything was doing just fine. You know, this girl was just horrified at the thought of losing this tooth, and this will probably last for a good long time. Probably sometime in her life she'll lose it, but I think she has a very good chance at having this last, you know, at least into her 20s. I just threw this in to show you the longest perforation repair that I've followed. This is a fifth, so there was a post-perforation here, and the key question when you see a post-perforation is, can you probe into it? If you can probe into it, probably the chances of getting a good result aren't very good. In this case, we couldn't, so I retreated it apically. This is again 99, 2000, somewhere around that time frame. Repaired it internally with MTA, and then patient went to his restorative doctor who put in a titanium post and put this shitty crown on this tooth. But here we are at 15 years later. The perforation repair is doing well. The shitty crown is still on there. Again, this is a time frame when implants were just kind of starting and they weren't a mainstream thing. And so we did a lot more heroic stuff back in those days than we do today.
Well, probably you'd be doing just as many heroic things if they came to you, but I mean, there's just a tendency to put implants in. That just is the way it is right now.
Well, my referral base, they're very much into predictability. They want to do stuff that's predictable, and so consequently we're the same way. And so we do a little bit of heroics these days, but for the most part, it used to be back in that time frame, the 90s. Our thought was if you could get 5 years out of a tooth, that's great. That's a reasonable goal. Nowadays, 5 years, with most people that refer to me anyway, 5 years, they're not really looking for 5-year successes. They're wanting 10, 15, 20 years. So most of the teeth that we treat, we think they have at least a reasonable expectation of lasting that long. And so today, this tooth not only was it perforated, but from a restorative standpoint, this is a poor tooth from a restorative standpoint too. But this shows you what's possible anyways. Today, this isn't necessarily what we would do, but 17 years later, everything is fine. So it just shows you what's possible. When I show this case to groups, I ask them, what do you see when you look at this? And so severe wear, looks like maybe a vertical fracture here, maybe some cervical resorption, maybe some apical resorption, a large radiolucency that's kind of off-centered. Those are all negative prognosticators for the long term. Also very calcified canal, which makes the endo a little bit difficult. So this patient, the plan was she has severe wear everywhere in her mouth, just like you see here. And the plan is basically to put crowns on all of her teeth. But she can't afford it at this point. And so they wanted, this tooth kind of has a poor prognosis. We don't know for sure, but it probably has a poor long-term prognosis. And the demise of it may very well be the cervical resorption if it's progressive, because it's in an area that's difficult to treat. So the plan was to do endo on this tooth, to keep it around. Well, she's going to take her a couple years to save up the money. Try to get the bone to heal. Again, I told the patient probably 18 months. She said, that's fine. I'm not going to be ready yet anyway. And try to make this into a better implant site with the anticipation that probably, later on down the line, the prosthodontist will decide whether he's going to restore this tooth or extract it and replace it with an implant. The scan just shows the cervical resorption, the apical resorption, and this makes the apical resorption makes the endo less predictable. Fairly large radiolucency. So we started the root canal treatment, and again, I got a little carried away with the calcium hydroxide. One of the things I want to point out is how conservative this is too. Conservative access, conservative shaping. When you have a small canal, there's no reason to prep it to a big size. All you're doing is weakening the tooth. There's no reason to make a great big old access here. Trying to leave as much of the tooth behind as possible. So after a month or maybe a couple months of calcium hydroxide, patient's asymptomatic, we completed treatment. And then now here she is at 18 months. She's pretty much completely healed. She still doesn't have enough money for her rehab, but this tooth is doing well. Maybe the resorption here has progressed a little bit. It's hard to say for sure. But probably another year down the line, something like that, then they can make the decision on what they're going to do with this tooth. And if they decide to put in an implant, now it's a better implant site than it was before. I mentioned we deal with resorption a lot. It's like an epidemic in this country. Sometimes when they come in, they're big enough that we deem them to be inoperable, but if the patient's asymptomatic, we don't do any treatment. We just follow them. So I've followed this patient since 2007, and it's maybe gotten a little bit worse. It hasn't changed very much, though. We did a scan in 2011, you can see. So we're 11 years out now. We haven't done anything with this tooth, and this may go indefinitely without requiring any treatment. So we're not in a rush to extract these things. And as long as they're asymptomatic, a lot of times we just leave them alone and follow them. I have a whole bunch of these that I'm in the process of following just to see how many are progressive and how many kind of stabilize. This is the longest one I followed. This is 2001. Saw the patient again in 2005. And here we are, 2017. This is a Schick radiograph, and this is Kodak, so they look a little bit different, but there's been very little change in 16 years, and this patient's never had any symptoms. Actually, the only change is that the restorative doctor put a crown on the tooth, which I'm not sure why exactly, but as far as the resorption goes, as severe as this looks, it's never caused any symptoms, and there's not been a reason to do anything with it.
So does that mean as a rule you won't treat external resorption unless the patient is symptomatic?
Generally speaking, that's true. It depends on how accessible, how extensive the resorption is. For the small ones, when they're asymptomatic, if they're accessible and easily treated, we'll generally treat those. I'll show you some examples. When they get big like this, I mean, this looks terrible, and we're trained as dentists. Well, don't just stand there, do something. But the best thing I've found in this situation is don't just do something, stand there. Because many of these will last for many years without doing anything. Sometimes the resorption can be very extensive and destructive to the dentition. Here's an example. Here's another example. This is totally destroying this patient's dentition. And unfortunately, we see a fair number of these. This is an example again of pre-implant orthodontics. This kid was, I forget, 14 years old. Braces were taken off and had pretty extensive resorption in this tooth. So he was in fact, I can't remember if he was symptomatic or not actually. He may not have been, because back in this time frame, this was 8 years ago, I hadn't maybe come to the conclusion to just leave him alone. Sometimes you can get historical radiographs and see if this is progressive. And if it is, then that pushes us more towards treatment. And that might have been the case here. I can't remember. So anyway, made access. And we have a protocol that we follow. It takes several appointments. We go in, debride it, and place calcium hydroxide. And after a few of these, the calcium hydroxide fills up the whole space, at least in 2 dimensions. And then we'll obturate this gutta percha apically, a fiber post, and composite. This is all composite. You see, I got a few voids in there. So this is a 4-year recall, and this is an 8-year recall. I actually just saw this patient last week. So he's 22 now, and who knows how long this tooth will last, but if and when it fails, and when they fail, usually they fracture. And when that happens, then he has a nice implant site here, and he's old enough. Another example, same thing. You can see this. I mean, look how extensive this is, and yet this is all treated internally. No surgery, no flaps or anything. Many of these, as long as the coronal part of the tooth isn't broken down at all, you can just treat them internally. We have this kind of protocol we've developed, and we've published some stuff on it. This is a 4-year recall on this patient, so he's 19 now. This is the longest recall that I have on a invasive cervical resorption. So I call it invasive cervical resorption. There's about 10 names for it in the literature. You see all kinds of different names. One of the reasons why there's so much confusion about it, most of these that are referred to us, the provisional diagnosis, they say is internal resorption, but internal resorption is pretty rare actually. Almost all the cases we see, like 90% of them or more, are invasive cervical resorption. And that's what this was. Even though it looks internal, it started out here and then it gets into the tooth, penetrates, and it kind of hollows out the tooth. So that we treated this internally again, endo, debridement, restoration. And this is an 8-year follow-up, 11-year follow-up, and 17-year follow-up. So again, they don't all turn out this way, but they can last a very long time.
What about the trichloroacetic acid approach that I learned from you? I don't see any of that here.
Yeah, so. No, that's part of the protocol that we follow. So we make access. We debride it as best we can mechanically, and then we treat it with this very nasty caustic acid, trichloroacetic acid. What it does is it dissolves away the resorption, and it makes the resorption more obvious. It kind of bleaches it white. And so when you look in there under the microscope, you can see what's resorption and what's tooth structure. And so you just take a burr of this and remove as much of the resorption as you can. When you make access, it's usually a bloody mess because these are usually very vascular. The invading tissue is bone and vascularity. And when you get in there initially, you can't see anything because it's a bloody mess. So I'll just kind of clean things up blindly a little bit and put calcium hydroxide. That'll be the first appointment. And then when they come back, I'll locate the canals and instrument them. But you're doing everything pretty much blindly because of all the bleeding. When they come back, then after having calcium hydroxide in there a few weeks, things are dry and you can see what you're doing. And so then I'll fully prepare the canals. I'll do some more debridement with a burr, and when you do that, it starts bleeding again a little bit. But then when you apply the acid, it cauterizes and stops it. And it takes usually somewhere between 3 to 5 appointments to treat these internally until the calcium hydroxide expands and fills the whole space. And then that's when we finish them and obturate them. So yeah, that's the trichloroacetic acid does two things. It cauterizes the tissue so you can see what you're doing. And also we've got penetration points from the PDL that are coming in here. You can't eliminate those without perforating. But what the acid does is it cauterizes those. And if you do a good job, it stops the progression, and like it did in this case. And I have examples of other cases where we didn't do it in the progression. The resorption progressed. But the vast majority of the time, following this protocol, it's called the Hither's-A protocol, developed by a guy in Australia. It'll stop this, and you can get successful outcomes like this. I have lots and lots of cases that are more than 10 years out now.
From a periodontal standpoint, do you see benefit? Now that I'm seeing that you're observing external resorption, which is, I mean, it's interesting. I'm not sure we have a database on that, and you may be able to, I mean, this stuff is definitely publishable stuff in order to be able to show what observation does. I mean, we have the same data on prostate cancer right now. Sometimes observation or watchful waiting is as effective as treatment, and you're providing an additional database. Yet some of us will treat external resorption from the osseous crest or ICR by doing a flap using trichloroacetic acid and sealing it off from an external approach. Is that something you promote? You don't promote? Do you work with that? Do you recommend it? Are there certain areas where you would use it, wouldn't use it?
Yeah, so sometimes and I'll show you some examples here in a second, the resorption is an area that's easily accessible, where you're not going to create a periodontal defect, and those are the ones that we treat. If it's interproximal, you can only treat it really most of the time by removing a bunch of bone. That doesn't make sense. So those are the issues, how big it is and how accessible it is. And if we catch it early and it's accessible, and in fact, let me go on here. I'll show you some examples of that. So here's one. Sometimes you don't even have to do endo. If it's small enough with the scan, you can see how close it is to the canal. So this, you just flapped it, debrided it, restored it. And at 1 year, pulp's still vital, tooth is doing fine. Here's the opposite. Now this looked like a very good candidate, just a small resorptive lesion on the facial, not very close to the pulp. So I did the same thing, flapped it, debrided it, restored it, but then the patient came back 9 months later and tooth had developed symptoms, so I had to go ahead and do endo after the fact. And it's in these kind of cases, it's just kind of, you just don't know how they're going to turn out. A lot of times they do fine without the endo. If they get very big though, then we just automatically do endo first.
When you do those kinds of cases, and you're from the scan, obviously, you wouldn't expect you would need endo, but scans are scans, and teeth are teeth, and people are people. Right. Is there pulpal protection that you would use if, in fact, you were taking the external approach?
Say that again.
Pulpal protection.
Oh, protection.
Yes.
I usually restore these with glass ionomer, and so you're talking about like a liner or a base or something.
Yes.
So Yeah, and you know, a lot of liners are made of glass animal materials. So, um, you know, there's a couple of the old Mick Dragoo articles about using a composite Gerastore for restoring these, and that's fine. You can do that if you want to, but it doesn't have any magical properties. I've done some with it. Gerastore doesn't polish very well, and you have to. There's more steps to it. You know, you're supposed to use it with a dent and bonding agent, and I like just using glass ionomer, you know, resin modified glass ionomer. There's, you know, isolation sometimes is an issue with these, and so I just want to get in there and restore it. And so with glass ionomer, you know, it doesn't require any kind of pulpal protection now.
Thank you.
Yeah. So let me move on. This, another one, you know, you can see the resorption here. This is an old case of mine. This was accessible, and we flapped it and we put a rubber dam on whenever we can. Here it is restored, here it is post-operative, and here it is at 12 years. Now nowadays, actually, I would probably put a fiber post in there to help strengthen the tooth. But I wasn't doing that at this point in time. Here, this is the clinical picture at 12 years. Yeah, so today you can see there's a fiber post in there. And, you know, we're all taught in dental school that fiber posts don't make teeth stronger, or that posts don't make teeth stronger. And that's based on metal posts back in the 80s and 90s, a couple of studies. The fact is, if you look at the literature since 2003 with fiber posts, they do in fact make the tooth stronger. There's overwhelming literature showing that. In fact, it's one of the best documented things in all of the literature. So so the way we do them is we prepare the canal to do the endo, and we don't take a twist drill and make the canal bigger. We fit a post into the existing space, so we're not removing additional depth to put a post in there. And so that's what we do pretty much routinely in single tooth anteriors and premolars, not so much in molars. Sometimes you can't place a rubber dam, but you can use a light cured composite to get good isolation. As you can see, here's another case. This is the longest surgical recall that I have. Patient came in, they'd had ICR is often misdiagnosed as decay, and that's what had happened here. They'd placed a restoration, but the resorption had progressed. I used to get a call every once in a while from a restorative dentist. They'd say, "Hey, I was going to restore this carious lesion, and I dropped into it, and it bled like crazy. And I know I wasn't in the pulp. Well, it's because this resorption is so vascular." So in this case, completed the endo. I think Eric Rindler did the surgery here. We've done a lot of these cases together. If the surgery is easy, I'll do it myself. But when it's more difficult, I'll usually defer and let him do it. Frankly, he's a better surgeon than I am. So I completed the endo, and then he flapped it and debrided it and restored it. And here we are at 17 years. And then I recently saw this patient again. Here we are at 19 years. We've lost some bone on the distal here, but basically, I mean, that's pretty good, 19-year recall. How are we doing for time here? Am I over my time quota?
You know, I didn't. I don't know when we started, but we've got a few minutes. Go right ahead.
Okay,
this is so interesting.
Okay.
You have unlimited quota as far as I'm concerned.
Okay, well, I've got probably 15 minutes more here.
That's great.
So this is an example. We use something called decision points sometimes in deciding when and how we're going to treat certain patients. This is another example of pre-implant endodontics, probably. When you look at these teeth, you know, from a restorative standpoint, they're not very good, great big buildups. There's a threaded post in the mesial root here. That's a negative thing. It's large radiolucency, or I mean, an oral surgeon wouldn't say this is large, but to an endodontist, this is large. And when I probe along the mesial root here, I could probe all the way to the apex. So I was pretty sure that this tooth was cracked. Also, the third molar had a broken lensular spiral in it. So I told her, you know, these teeth are kind of losers. Why don't you just have these teeth extracted and have some implants put in there? You've got lots of vertical bone. You've got nice wide, nice broad ridges. You know, I can retreat these maybe, but I really think in the long run you're going to end up with implants in this place. And I want you to just go ahead and do that. Now, this lady, incidentally, was a local dentist. I'd never heard her name before. She'd never referred a patient when she showed up on my schedule. She'd had all this work done in Russia, actually. So she said, no, I don't want, you know, I'm only 39. I don't want implants in there. I'd like you to retreat these. So I said, well, my feeling, because of the deep probing here, probably this tooth is cracked. And if this tooth is cracked, it's going to need to be extracted. And this tooth is in better shape than the first molar. I really don't think this is the best treatment. But, you know, you're the boss and we'll do what you want. So I said there'll be 4 decision points in this case as we go along. The first one is when I start treatment on this tooth, when I get inside there, if I find that it's cracked, then you need to just have all of these extracted. If we get in there and it's not cracked, then I'll put calcium hydroxide in these teeth and we'll go for a while and we'll see what kind of healing we can get. She also had a sinus tract. So I said, these are going to be the 4 decision points in this case. The first decision point is whether the tooth is cracked. If it's not cracked, then the second decision point will be, does the sinus tract heal? And the third decision point will be, I want to see this deep probing reduced to at least less than 5 millimeters, and hopefully less than that. And then the fourth decision point will be, I'm going to want to see clear evidence that the bone is healing here. And if all those things go well, it's going to take about 3 to 6 months, but if all those things go well, then I'll complete the treatment and you can have new crowns made. If along the line things aren't going well, then we'll just stop and we'll pull the plug and go to plan B, you know, extraction, grafting, and implants. So she said, okay. So I made access into the second molar, and in fact, this root was not cracked, surprising me. So I took the post out of the first molar and took everything out, put calcium hydroxide in. And then I had her back at 1 month, and the sinus tract was healed. So we made it past the second decision point, and things were going our way. When I probed initially, I didn't get much probing either, but then I anesthetized her and I probed more forcefully. I still could probe, you know, all the way to the apex. But the tissue was a lot tighter and healthier looking, and it just seemed like things were going our way. So I changed out the calcium hydroxide. I saw her at 3 months, and now I couldn't probe at all along that mesial. It was like 3 millimeters on the mesial root, even under anesthesia. And maybe there's some evidence of healing. I wasn't really sure. So I changed out the calcium hydroxide again, and in 5 months, clearly this is healing, okay? So everything has kind of gone our way, and normally I would have just finished the treatment at this point, but this, I kind of thought I might be showing this case when I lecture, actually, truthfully. And so I changed out the calcium hydroxide 1 more time, and at 7 months, it was almost completely healed. So I took out the calcium hydroxide. One of the things we do in our practice is that we do all the initial restorative on these cases before we send them back to the restorative doctor. So I completed the endo, did build-ups, and just kind of rough prepped these teeth. And then they went back to her boss, actually, who made new crowns. And this is at 18 months. You can see everything is doing well. And here she is at 5 years. And then again, I just saw her recently. She moved to Dallas not too long ago, but she was in town and she stopped by. She finally got her 3rd molar extracted. And here we are at 7 years. So one of the things, I've lectured a lot to like implant study groups and implant surgeons. And one of the things I've asked many of them is, if a patient asks you how long the implant's going to last, what do you tell them? And they usually say, oh, well, you know, you can't predict that kind of stuff. So I said, but patients must ask you that question sometimes. What do you tell them? And they'd say, well, you know, there's this study and there's that study. So finally I'd say, look, I'm your patient, I'm sitting across the table from you. You're proposing to put a couple implants in my mandible, my posterior mandible, and I want to know, how long do you think these are going to last? And so the answer I usually get is 20 years or more. Okay. So what I tell patients usually is that if we're going to do endo, unless it's pre-implant endodontics, endodontics, if we're going to do endo on a tooth, I'd really like it to have a good chance of lasting 20 years. So it's one of the reasons why we don't treat so many compromised teeth anymore. So I told her I don't think these are going to last 20 years, but here we are at 7 years. They're doing fine. What's going to happen eventually, probably to one of these, is going to develop a vertical root fracture because these teeth are so compromised. But even if and when that happens, again, now there's all native bone here. These are, somewhat better implant sites than they were before we started. So she gets some benefit out of this anyway, even if she loses the teeth at some point. And this is just a scan at 7 years showing the healing. And this is the interproximal view. You can see pretty much complete healing. When I talk to groups of implant surgeons, a lot of them have the idea that when you get these large radiolucencies that they won't heal just with endodontic treatment. And that's true in some cases, but I put in a few cases showing where that wasn't true, or we've got some post-op scans. So this is an example of that. Retreatment here, complete healing. And on the scan, you can see large amount of bone loss. And on the recall scan at a year, we've got pretty much complete healing. So it doesn't always work this way, but many times it does. Do the endo, see how it goes before considering doing surgery. Another example of the same thing, pretty much complete healing at 13 months.
Frankly, from a management standpoint, this is an outstanding way of treating, and most of the people in our group are periodontists, of course.
Right.
Sometimes we're in a rush. It goes back to the osteosurgery days where we do initial prep, and we do initial prep in order to prepare for surgery, and then within 2 weeks or 6 weeks of the initial prep, you're doing your full flaps and osseous. Well, that's pretty much gone by the wayside. But still, we have this tendency to rush. We have this tendency to get it done.
Yeah.
And I've got to tell you, we have a pretty successful practice here. And it isn't a successful practice because we rush in and we do a number of different procedures. It's a successful practice because of the observation, and it's the time that you take and the amount of follow-up that you do in order to be able to show the patient what's going on. And the patient becomes your advocate. If you're looking for, particularly the younger people in our group, if you're looking for long-term success, look at what Dr. Schwartz is doing, because it isn't just the clinical treatment, although that's outstanding. It is the fact that he and the patient are working together towards a particular outcome. And in a couple of weeks, we're going to have Brian Vence on talking about co-diagnosis. This is what this is all about. It's the patient working with the doctor, or the doctor working with the patient to produce the best result. And believe me, for your long-term reputation, it's going to make a big, big difference. So that when you're in your 60s, like I am, people will come in because they know that this kind of observation, this kind of follow-up is done.
And a lot of the guys that I work with are like you. They're not in a rush to do things. They have a fair number of, treatment plans that take 2 or 3 years to complete. There's ortho involved, there's implants involved, and they don't mind waiting a few months on the endo. There's the perio penalty box. We're kind of the endo penalty box. And what's happened with us over the years is, we've attracted a group of referring doctors that they like what we do, we like what they do. There's good communication in both directions. There's respect in both directions. Those are the kind of guys I want to work with. And unfortunately for me, so I'm in my 60s also, a lot of those guys are retiring now. And so we've been the last couple of years trying to seek out some of the younger dentists and kind of bring them along in this kind of mindset. And there aren't very many of them out there is what we're finding. Most of them, they want treatment done in a single, the endo treatment done in a single visit so they can get the patient back and get the crown on there. And in many cases, that's just not the best way to do things. And I've always said when I hire people to work in the office, I tell them we're not trying to be everybody's endodontist. We just want to work with the people that kind of share our philosophy. And it takes a long time to attract those kind of people. It took, I feel like, maybe 10 years to get everything optimized in private practice, to get my skills up to whatever level I'm capable of. to get the right staff working for me and loyal, work well together to get the right group of referring doctors. And once you reach that point, then private practice is just great. Life is great. But unfortunately, those guys retire and die at some point, and that's what's happening now.
That's the reason for the Institute for Dental Specialists. Thanks for the sales pitch, Rick.
All right, so a couple more examples. Again, big time, a lot of bone loss just with endo. He got a little carried away with the calcium hydroxide too. So this is a book that I was the primary author on. That it's an endo book, but it talks about a lot of these things that I've talked about today. There's several chapters on resorption, and there's a certain amount of philosophy in there. This is designed really for endo residents and young endodontists, but there's a lot of stuff in there that's of value to anybody in practice. So, and in the spirit of full disclosure, I want to tell you that I get $3 for every one of these that are sold.
Thank you.
And then this is one of the articles that we did on invasive cervical resorption, kind of everything that you need to know, actually. I guess the only thing I forgot to put in this article was how to get the trichloroacetic acid. You want 90% aqueous trichloroacetic acid. You can have it made at a compounding pharmacy. You have to be very careful with it, though. You don't want to splatter it or anything. It's nasty stuff. And then this is my email. I'm happy to correspond with anybody. I have people all over the world that email me with questions about cases and stuff. And I'm happy to respond, within reason. So that's about it. We learn in dental school about mulberry molars, so this is a strawberry molar.
Very good.
Anyway, thanks for having me, Lee. Always a pleasure to talk to a group of really high-level practitioners.
Thanks, Rick. Could I ask you a question? And you
Sure.
covered it in a recent email, and I think it's important, particularly what's going on right now. And by the way, if you don't feel it needs to be part of this presentation, that's fine. I can certainly cut it out of the recording. But the question has to do with this perception that there is a relationship between endodontic procedures and general health or general disease.
Right.
And I thought what you wrote was excellent. Can you, particularly given what's going on right now in the media, could you address that a little bit?
Yeah, so talking about Root Cause, it's called, the thing that's been on Netflix. It's actually been around for a while. It's just got onto Netflix recently, and a lot of people have seen it. So basically what it says is that it says a few different things. One of them is that 97% of the people who have brain cancer also have root canals. And so the implication there is that root canals caused the brain cancer. So you can't answer that question looking at it the way they describe it. It's something called a reversal of the conditional. The real question is, for people that get root canals, what percentage of those people go on to have brain cancer? And that's actually been studied. And the answer is it's the same as in the general population. Kind of all of the things in this root cause are like that. They're kind of inferring one thing, that there's a relationship between one thing and another, and that's really not there. That really doesn't stand up if you know anything about research and about conditional probabilities and that sort of thing. And then there's, testimonials, which you can find testimonials on almost any topic. The reality is what's been studied, at least as far as root canal treatment and systemic disease, what the literature says is that any infection, whether it's endodontic or periodontic, has the potential to have an effect on your overall health, on your heart, on your brain, that sort of thing. Eliminating the infection is a positive thing because it lessens the chance of that causing a problem. So periodontal treatment, endodontic treatment, you're actually lessening the probability of having problems, having systemic problems. One of the things they talk about is that there's still bacteria that remain in the tooth. That's true. You generally can't eliminate all of them. But the way we judge success or failure is, number one, do the patient's symptoms go away? Number two, does the bone heal? And if those things happen, we're not concerned about a few bacteria left behind in the tooth. The fact is that your body is full of bacteria. All different areas of your body have bacteria. In fact, 90% of the DNA in your body is bacterial. Only 10% of it is yours. So as long as the patient's asymptomatic, as long as the bone is healed, those are the goals of endodontic treatment. Now, some patients come in and they're just so convinced. They're so concerned, they're so convinced. And for those patients, maybe they're better off having the teeth extracted. I mean, it's their body, it's their decision. That's what I tell them. My role is just to give you as much information as I have and to give you my opinions, but ultimately you have to make the decision. It's your body. If you think it'd be better off having that tooth extracted, then have it extracted by all means.
Very good. Great answer. Dr. Rick Schwartz, what an outstanding presentation. I really thank you for sharing this information with us, the Institute of Dental Specialists. And I've learned a lot today, and I've learned a lot from you over the past several years. So thanks for all the contributions you're making to us and to dentistry.
Okay, thanks. Same to you.
Thanks.